Okay, hello everybody, and welcome to this afternoon's Echo. I'd like to welcome Dr. Washington Mudini, a histopathologist based at Fitzgerald Gordon Medical Center, where he is assisting us a great deal with our liver pathology. He is going to be looking at the pathology of MASLD, and he's got a few interesting cases to show us. So, Washington, over to you.
Thanks, Bilal. Good afternoon, everyone. It's such a pleasure and honor to be able to share what we see on a regular basis with you. How I'm going to structure this is I'm going to share a case at the beginning, and then we'll share clinical information about the case, and then I'll go into a slide presentation around MASLD, and share at the end maybe one of the main differentials, which is alcoholic liver disease. Then we'll open the floor for discussion. The main purpose is to highlight what we see as pathologists, and to integrate it obviously with what you see from a clinical point of view. Feel free to ask me questions either during or in the chat box or at the end so that we all can learn. I'm going to put up the presentation first. Let's confirm when you can see the screen.
Go ahead, Washington, we can see.
Brilliant.
Just put in presentation mode.
All right, let's try that.
All good.
Great. Like I said, I'm going to present about steatotic liver disease from point of view of for pathologists. We do biopsies essentially to confirm diagnosis because we know now that there are many modalities that can pick up steatotic liver disease. But biopsies are also useful when you want to exclude concurrent diseases, which may be present. They are also important for prognostication and risk stratification. So the two cases I'm presenting are literally cases I received this week on Monday. The first case is a 26-year-old female patient, background ITP, with progressive liver dysfunction. She also has a metabolic phenotype and newly diagnosed diabetic with hypertension. She had a MELD score of 19. She was previously on prednisolone. It was more recently changed to Revalade for the past 2 months. She has no history of alcohol use. Recent lab investigations showed a cholestatic liver injury, both cholestatic and hepatocellular liver injury. She had an abnormal lipid profile, raised CRP and prolactin levels. Platelet count was 551 and a white cell count of 19.9. All right, I'll move to the microscopy. Allow me to change and shift.
And we can see that.
Brilliant. I'll just put that in full view.
All good.
All right, so I'll share with you the microscopy. We received two slides. I mean, two cores about 20 millimeters each. For those who maybe haven't seen what a normal liver biopsy would look like, let me just put up maybe not that we get normal liver biopsies, but just a general hint of what it should look like. It should look something like this, with portal tract, uh, portal tract and a central vein with maintained portal-central vein relations. If you're taking the asana view of what the normal anatomy of a liver should look like. So it should generally look like this. This one shows a bit of fibrosis at the end, but the rest of it is more or less normal architecture. This particular case shows extensive steatosis on low power, and I'll go on high power to show you what that means. Essentially, there are these large droplets of or vacuoles within the cytoplasm of hepatocytes. It's mainly centered around zone 3 with extension to zone 2 with relative sparing of zone 1. This is a very low power view. I'll go down just now, but just to give you an appreciation of what this is the entire core, first core. This is the second core. And it's showing more or less on low power the same features where you have marked centrilobular steatosis, mostly macrovesicular or large droplet steatosis, extending to zone 2 with relative sparing of the portal regions and zone 1. It's a bit fragmented, but the main pathologic features are the same. So if we now go into specifically the portal regions. So let me just close this door. Sorry about that. So one can appreciate that within this particular portal tract, there is relative expansion by one, fibrosis, two, a mixed inflammatory infiltrate that is composed of lymphocytes, some histiocytes. Also, there are some eosinophils. In addition, this is the normal or native bile duct. You can see that there is evidence of biliary epithelial injury. This is signified by cytoplasmic vacuolation, hyperchromasia of the nuclei, as well as loss of biliary epithelial cells. So that's the first portal tract. We'll go into another portal region, which shows more or less the same findings. Here's another portal tract. Again, mild expansion of this portal region by fibrosis, inflammation, with evidence of biliary epithelial injury. This will be the bile duct, and it shows hyperchromasia again, loss of bile duct epithelium, focal interface activity with a few neutrophils as well, and that's an eosinophil. So that's what's happening in the portal tracts. There are bile ducts represented in all, I think there were 19 phototract, so there's no ductopenia. The main findings in this biopsy that helps us clinch part of the diagnosis is the already alluded to small and large droplet steatosis, which I've given an estimate of about 75%. So what does that look like? So there's expansion of the swelling or enlargement of the hepatocyte with this large droplet with the nucleus pushed to the side. You can see that there is relative variation in the size of the fat droplets within each hepatocyte. They are small, medium, and large. And the theory is that essentially they start off as small and then they start to coalesce and they become this one large droplet pushing the nucleus to the side. In addition, what you can see in this particular focus that I've put up is the presence of this brown pigment within cytoplasm. This is some cholestasis, intracytoplasmic cholestasis. There are some regions which show also very focal intracanalicular cholestasis. Let me see if I can find them. So something similar to that, where it almost forms like a solid mass. So the other thing that we can see is the presence of what we call ballooning degeneration. Let me try and find a very good or a classic example of that. I mean, it's everywhere. So the enlarged or swollen cell shows relative rarefication of the cytoplasm, with sometimes clumping of the cytoplasm to form what we call Mallory-Denk bodies. I should have dotted one. Let me see if I can find that particular one. In any case, I'll see if I can find it. But what is important for us to realize is that this ballooning degeneration is readily identifiable, maybe 2 to 3 per 20 times high power field. All right, so that's quite an enlarged and ballooned hepatocyte. A bit of possibly microvesicular or foamy appearance to that particular case, particular example. In addition to the steatosis, which is small and large droplet steatosis, the cholestasis, what we can also appreciate is the presence of lobular inflammation. Now, we already noted that most of the inflammation within the portal tracts is mixed. That means it's lymphocytes, histiocytes, some scattered eosinophils. The majority of the lobular inflammatory infiltrate is composed of lymphocytes, such as one that you can see there. This is an hepatocyte, and it's clearly being attacked by a number of inflammatory cells. I was looking for Mallory-Denk bodies, which is essentially clumping up of keratin material. This is an example of that. So, in essence, on H&E, one can appreciate that there's extensive steatosis, mostly large droplet or macrovesicular steatosis, comprising about 50, 75%. There's also evidence of portal inflammation with biliary epithelial injury and some cholestasis. The next stain I would like to share with you is the serous red stain, which is a stain we use to highlight presence or absence of fibrosis and its extent for, in part, prognostication, as well as to establish if there is evidence of cirrhosis or not. Most of the fibrosis will naturally be within the portal tracts, such as one where you can see there. There's also evidence of centrilobular fibrosis as marked by this red staining within around this particular vein for centrilobular region. One can appreciate that in addition to increased staining around the vein, part of the fibrosis is actually going between the sinusoids, and some of it is around the hepatocytes. And this is more or less limited to centrilobular regions to varying degrees. So that's just control. This is the one we're looking at. This is another fragment showing more or less the same thing, where that's a part of the portal tract. And you can see this is centrilobular region, again with evidence of centrilobular fibrosis. Focal, sinusoidal, and pericellular fibrosis. An important stain that just highlights evidence of cellular injury is a PAS-D stain. On the PAS-D stain, it will highlight macrophages that contain ceroid pigment. And in a hepatic process, one would expect numerous macrophages within the portal tracts, as well as within ceroid pigment within Kupffer cells in the sinusoids. So this red staining is actually ceroid pigment in some of the Kupffer cells within sinusoids. In areas where you have a bit of inflammation around some of the hepatocytes, you also get some ceroid pigment within macrophages. What is interesting around this is you can actually see neutrophils. I'll get more in detail about this, because neutrophils you'd expect to see more of them in alcohol-related liver disease, but they've also been described in MASH, metabolic associated steatotic liver disease. This phenomenon is called satellitosis or neutrophilic satellitosis. So when the pathologist report talks about satellitosis or neutrophilic satellitosis, it is that phenomenon that they will be describing. Other stains that we do include reticulin stain, porcine, iron. Sometimes there might be increase in iron within the reticular endothelial system. In this particular case, it's not necessarily increased, but you may see a bit of iron within macrophages, but it's not always, but there's no increase in actual iron within hepatocytes. So that was the case. I'll share with you the rest of the presentation, including my conclusion. I'll just move back to the PowerPoint presentation.
Wash, I'm not sure if you want to open up for any further comments or questions at this point.
Oh, yes, yes.
Yeah. Let's just see. I don't see anything in the chat yet, but I know you talked a little bit about the fibrosis that you were spotting. Just what sort of
Yes.
degree of fibrosis? What staging are we talking about?
So for this particular case, I gave it an F1 fibrosis. Although there is focal, possibly septum formation, but I feel like it's too little for us to go to F2 fibrosis. If
Okay.
that answers,
And
yeah.
and you said that she was on a whole bunch of steroids and immune modulators. What exactly was that for?
So she's got ITP, immune thrombocytopenia,
Ah,
and
okay.
yes, yes.
All right, all
So she
right.
was, yeah.
Okay. And nothing further than to suggest any other um anything else autoimmune mediated then, hey?
Not from the histological features. And
Okay.
I think from her investigations, I think, and I'll just double check, the autoimmune markers were negative.
Okay. So that's great. Go ahead. If no one else has anything further to comment, maybe let's go ahead with the next case.
So the next case I'll present as a differential in the end. What I want to actually delve into is first my conclusion on this case and then discuss metabolic associated or steatotic liver disease in general.
Cool.
So my conclusion for this particular case, I concluded it as in keeping with metabolic dysfunction associated steatohepatitis. Give it a brand grade 3, stage 1. I'll try and explain what that means in the presentation. In addition, however, there is evidence of biliary epithelial injury, inclusive of there's moderate to marked lobular inflammation, portal inflammation with biliary epithelial injury with some eosinophils. So what I raised as a second or additional pathology is that of a drug-induced liver injury. In this context, she was put about 2 weeks ago on a drug called Rivolade. And this, when I checked on the Liver Talks website, is known to cause a mixed hepatocellular cholestatic liver injury, which would fit in her case. So that's a small twist to what you would normally see.
Wash,
In
just referencing the Brunt staging, you want to just maybe just go through that classification, or is that part of your
yes,
slides?
that's part of my slides. That's part of my slide. All right. So just going a bit in history, we know that fatty liver disease, as it was called, from some time ago, was generally divided into alcoholic liver disease and non-alcoholic fatty liver disease. I think NASH in particular was first described around the 1980s, if I'm not mistaken. But from around 2020, there's been a move to move away from the term non-alcoholic fatty liver disease to metabolic associated steatotic liver disease. This is in part to acknowledge the root cause. And we know that some people find the use of the word fatty stigmatizing. So we're trying to destigmatize and encourage knowledge and direct treatment as well. The other word that is commonly used in this context is MASH. From a histopathological point of view, MASH is an aggressive form of MASLD and is characterized by ballooning degeneration, which we saw in our case, and lobular inflammation, which is mostly lymphocytic, but you may have some neutrophils. And presence of neutrophils, depending on the extent of their involvement, does not necessarily now make it automatically alcohol. So as a general overview of this new nomenclature, the general umbrella term now preferred is steatotic liver disease, where to one end of the spectrum, I know now the spectrum has slightly been extended. To one end of the spectrum, you have metabolic dysfunction associated steatotic liver disease, MASLD, with this subset of the more aggressive form, MASLD, being called MASH. Then you have, to the other end of the spectrum, alcohol associated liver disease. In between, you can have a mixture of both, depending on if the patient is both obese and is taking excess amount of alcohol. You can see the recommended cutoffs there for women, 140, and for males, 210 on a weekly or daily, 20 to 30 daily average. You can also have steatotic liver disease with a specific cause. So drug-induced liver injury, some monogenic diseases, and sometimes we cannot find the cause of the fatty liver disease. So with respect to general pathogenesis, three main pathogenesis for MASLD are identified. Type 2 diabetes, being overweight, obese, and metabolic risk abnormalities. And we know, I think I've seen some authorities say you need 3 of the 7. I see here is 2 out of 7, where we look at things like waist circumference, triglycerides, HDL, etc. So from a pathologist point of view, when I'm looking at liver biopsy, we try and grade it into grade 1, 2, and 3. Um, anything, anything above 5% is considered significant. And I've tried to put pictures here where you can see a bit of fat, but this is less than 5%. It is reported, or it may not be reported because we consider this to be within normal range. But when it's grade 1, it's between 5 and 33%, grade 2 up to 66%, and grade 3 above 67%. So that's what we use when we talk about the extent of steatosis. So what is the disease? Maybe spectrum that you can see. I don't want to say normal history or normal progression, because not everyone follows this sort of progression. But maybe for just conceptualization, this can be helpful. So we said we consider steatosis to be significant if it's above 5%. I've showed you how we estimate that. When you now have inflammation with ballooning degeneration, that's MASH. And the fibrosis, what Bilal was asking and I was showing on the serious red stain, usually starts around zone 3 and can expand beyond zone 3 towards zone 1 or towards the portal tracts, where you now have bridging fibrosis. And when this is extensive in the liver, then you get cirrhosis. These patients are also at risk of developing hepatocellular carcinoma, but particularly the variant that develops in this patient is the steatohepatic variant. Another point of discussion is around what we mean by macrovesicular steatosis. I'll show, or actually I can, sorry. the diagram top right, and just like I was trying to show in my presentation, you have these large, medium, and small droplets with pushing of the nucleus to the edge. All of that is seen under macrovesicular or large droplet steatosis. In fact, the encouragement these days is to try and not just use the word macrovesicular, but rather, for ease of understanding, use the term large droplet steatosis, knowing full well that it encompasses large, medium, and small droplets. In addition, just for clarity, in this particular picture, there is evidence of lobular inflammation, which is mostly lymphocytic, with ballooned hepatocyte on the edge then. So the next point is to emphasize how important it is to now differentiate between microvesicular steatosis and small droplet steatosis. If small droplet steatosis are these relatively smaller fat globules within hepatocytes, then microvesicular steatosis are what I'm showing now, where you have this foamy appearance to the cytoplasm, relatively central nucleus, and accentuation of the membrane. Why is it important to differentiate between small droplet steatosis and microvesicular steatosis? It's because the diseases that we see, these forms of large droplet and microvesicular steatosis, are different. The list is provided there. We see mostly macrovesicular steatosis in things like alcoholic liver disease, some genetic diseases such as PFIC, patients with protein energy malnutrition, and as well as patients who have gone small bowel resection. I think we see this on a relatively regular basis. Whereas with microvesicular steatosis, you can get it in alcoholic foamy degeneration, acute fatty liver disease of pregnancy, some genetic diseases as well. But the commonest scenario we see it in our practice is around use of certain drugs and toxins as well. I spoke about ballooning degeneration, and I was trying to show you pictures in that in my presentation. I said these are these large swollen hepatocytes with rarefied cytoplasm, and they contain Mallory-Denk bodies, which are intermediate filaments. Sometimes you may see giant mitochondria as well. We spoke about lobular inflammation as mostly comprising lymphocytes. The one at the bottom actually shows what I referred to as satelitosis, because it's mostly neutrophilic. The case that I showed you showed relatively mild to moderate portal inflammation. Usually the portal inflammation is mild. When it gets to be significant, like the case that we saw, then you have to think of other differentials or concomitant diseases. So autoimmune being one of them, hepatitis C being the other. The case that I showed you showed fibrosis within the centrilobular regions, such as the case that's right at the top. This is a Mason's trichome stain. It's different from the red one that I was showing you. It's blue-green, depending on the lab, I guess, but essentially it's meant to highlight the same thing. This centrilobular, sometimes pericellular fibrosis, this would be a grade 1, like our case. This would be considered a grade 2, or sorry, stage 2, not grade 2, stage 2, because grading we use for activity or / inflammation, and staging we use for for fibrosis. So here you can see that now, in addition to the centrilobular fibrosis, there are some fibrous sector that are now extending towards the portal regions. So that becomes stage 2. So Bilal was asking, what does that mean? How do we grade and stage? So there are a number of grading and staging systems. For example, the brand, the NAS, and the SAF. The one that we use is a combination of what is on your screen right now. So the first 2 tables essentially highlight the extent of activity or inflammation, and the last table is the extent of fibrosis. The grading is essentially 1 to 3, mild, moderate, severe. We look at the steatosis, which I showed you initially, where we have less than 5%, 5 to 30, less than 5% is considered normal. 5 to 33% would be grade 1. 33 to 66% grade 2, and above 66% grade 3. We interpret this in association with the extent of ballooning degeneration that you see within each particular case. And it's also relatively made into a 3-tier system where you have minimum or present or extensive. Like the last case or the case that I showed extensive ballooning degeneration, as well as steatosis that was above 66, I give it 75%. So that would automatically be a brand grade 3. We also incorporate the amount of inflammation, L being lobular inflammation and P being portal inflammation. And we count the number of foci of inflammation that you see per 20 times objective under a microscope. Again, this last bit is expanded into this table that you can see here, 1, 2, 3, where in the degree corresponding to mild or grade 1 will be less than 2 foci of lobular inflammation per 20 times objective of a microscope, with increasing severity up to grade 3, where you have more than 4 per 20 times field. I briefly touched on fibrosis. So when I showed the serious red stain and the Mason Stricum stain on the presentation, essentially it's staged 1 up to 4, where stage 1 is perisinusoidal fibrosis. This can be focal or extensive, but as long as it's limited to the centrilobular regions, it's stage 1 fibrosis. When you now start to get perisinusoidal with periportal fibrosis, whether focal or extensive, then you now move to stage 2. When you now have sinusoidal fibrosis with periportal fibrosis and evidence of bridging, then it's stage 3. And 4 is extensive architectural distortion, which is in keeping with cirrhosis. So stage 4 is the last grade. This is more or less a summary of what I've just said now, but maybe in a simpler way to sort of understand that the grading is grade 1 up to 3, and the staging is stage 1 up to 4, with the parameters that we just discussed. So at this point, maybe I can take a few questions before I show a case of the differential that is important for the other end of the spectrum, as it were. If anyone has a question or a comment.
Washington, that's excellent. Does the presence of alcoholic foamy degeneration alter the prognosis of alcohol?
So we use Salver grading, and Salver grading is used to in the prognostication. And the important parameters there do not necessarily speak to the foamy to foamy steatosis per se. It's more the extent of fibrosis and the pattern of fibrosis, presence or absence of cholestasis, and where the cholestasis is. Is it intracytoplasmic? Is it intracellular? But not and the extent of steatosis, of course, and activity. In short, no.
Okay. Yeah, there are two questions in the chat. Bilal?
Yeah, Dr. Adekoke has two questions. Do you want to unmute yourself and maybe ask, or shall I read them for you? The one is related to diabetes and whether or not that has a factor. And the other is just regarding how you would report this in the first case. In a clinical situation, would you put a note on the possible progression to F2 or leave it just as F1?
Okay, so maybe I'll let her answer or ask the first question, then we'll go to the fibrosis question.
I'm not sure if she's Dr. Dekoke, do you want to ask your question? Maybe I can
I can read it.
it's somewhat more clinical in that, diabetes obviously most certainly being part of the metabolic syndrome and would lead to some degree of fatty liver change. So certainly the diabetes history is significant.
Yep, I would agree with that. And if you remember the slide that I showed, the three main pathways, diabetes actually has its own pathway, but she has also additional metabolic derangements that are aiding and abetting. So yes. Then the other question is...
But just, sorry, on the factor of diabetes, it is the one disease which really MASLD progress. It is a bad prognostic factor. So it is the population group where you're going to find progressive disease in steatotic liver patients.
Absolutely.
Yeah. So that's the group to target if you want to find patients who have progressed to fibrosis, because they're the ones that will.
Doctors said they felt the fibrosis looked significant, although focal. Would you note that they may be more or maybe correlate with imaging? So the distinct advantage that I have in this practice is that we get to discuss cases with the clinical team, and often I get information about what they found on imaging and the extent of fibrosis sometimes or on the fibroscan, and we try to correlate what we are seeing. So in the particular case, after the discussion with the submitting clinician, we felt it's more in keeping with F1 rather than F2 fibrosis, but it's definitely not cast in stone. It's just highlights the importance of having your clinical colleagues to also give you insight on what is going on with the patient elsewhere. I don't know if that answers your question, Doc. All right. So we are not necessarily talking about alcoholic fatty liver disease, but because it's an important opposite end of the spectrum, and also because I received a similar case or a case that speaks to that this week, I thought maybe I can also just share. So I didn't summarize, unfortunately, the second case, but just to give you a bit of background, it's a 51-year-old male patient, multiple comorbidities with liver degeneration. He does not, he specifically denies taking any ethanol, but the submitting clinician thinks otherwise. In other words, they think that he is not being entirely truthful. But the point really is not necessarily whether they are being truthful or not. What I'm trying to highlight in this particular case are the salient features that differentiates or that make this case relatively opposite end of the spectrum in a patient with suspected alcoholic liver disease. So I'll just take you through the biopsy relatively quickly. You can appreciate on low power that already there is some expansion of the portal tracts. That's the first thing that you'll notice. You also see evidence of bile plugs. Some of it is within intracanalicular regions, and some of it is actually within is intracytoplasmic. At this power, we can just appreciate that there is some inflammation admixed with these hepatocytes. We'll try and see what is the nature of those inflammatory cells, but you can see that there is relatively minimal inflammation. Minimal steatosis. That's the first core. I'll go to the second core. More or less the same features where you have some suggestion of steatosis, some cholestasis, mostly intracytoplasmic, intracanalicular, and focally intraductal cholestasis. So that's intraductal cholestasis. What kind of inflammatory infiltrate do we have? So one can appreciate that there is extensive involvement of the inflammation of the parenchyma by a neutrophil-rich inflammatory infiltrate. In addition, I'll try and find a classical area of cytolytosis. It becomes difficult sometimes to differentiate between feathery degeneration as well as ballooning degeneration, especially in this case where you have both cholestasis and steatosis. So feathery degeneration essentially is these swollen hepatocytes with rarefied cytoplasm and cholestasis. You would see if you were essentially going to take away the brown pigment, you would call that ballooning degeneration. In other words, a classic finding with alcohol, I hope I can find it. I'm sure I actually did put a dot on this case. Let me just look for it. So these are well established and readily identifiable Mallory Denk bodies. In addition to, I mean, there's some there, these cytoplasmic eosinophilic globules, there again, there again. The round nature of the one at the bottom makes me consider a giant mitochondria. I'm not entirely sure. But also presence of neutrophils, that neutrophilic satellitosis that we spoke about. So this is the differential, the main differential, and you'll find to different degrees the amount of steatosis in each case, but the main clinching factors for me in this particular case is presence of ballooning degeneration, Mallory Denk bodies, satellitosis. The other thing that is sort of a clincher is when you look at the fibrosis on the serous red, you get what is classically described as chicken wire or pericellular fibrosis. I'll try and find an area that demonstrates that. So again, this is a serious red stain. And you can see that the fibrosis, instead of just being limited to the central lobular region, it is mostly around small groups of cells or around individual hepatocytes. That's so-called chicken wire fibrosis. I haven't scored this, but that's something that one needs to look at. We try and make it standard with our reports to provide a salver score and grade on cases of alcohol-related liver disease. Having said that, we had a similar case more or less 2 weeks ago that had classical features of alcoholic liver disease. It's important to remember that some drugs, particularly in last week's case, amiodarone, can cause features that look like alcohol liver disease. Tamoxifen can also do the same. And a number of other drugs that I cannot think of at the top of my head. So it's important again to correlate what you see under the microscope with what the patient has. Sometimes, like I said in last case, it's not always that the patient will either tell you everything that is going on or they will admit. So sometimes you might have to dig to get the full story. So let me just conclude. Then we open the floor to a few last questions before we close. Like I said, alcohol is a differential drug-induced liver injury, hepatitis C infection, and these are just differentials for steatotic liver disease. So you can get steatotic liver changes under the microscope and this list is by no means exhaustive. So we try to describe the steatosis, presence or absence of ballooning, inflammation, and the extent of fibrosis. We try to stage and grade each case. Just because I like digital pathology, the new things that are on the horizon is to try and see if we can get any algorithms that can help us to quantify all the factors that we consider when we are staging and grading. So that's fibrosis, inflammation, ballooning. And there has been some algorithms or programs that they have found to be quite useful. Between us as pathologists, sometimes I think there's intra-observer variability and inter-observer variability. So this in the future I can see can help to bring some standardization. Useful as it is, the current scenario, it can be improved. So what are some of the key takeaways? You need to see ballooning for diagnosis of metabolic associated steatohepatitis. It's important to evaluate fibrosis and the extent of inflammation for prognosis. Clinical correlation is essential. The third case I wanted to show was actually a patient who had a transplant for metabolic associated steatotic liver disease, in which MASLD has recurred, but I think the point is made. These are some of my references. So we can open the floor to questions or comments or different experiences from different departments.
So Bilal, I mean, you're doing fibrous scans, and you're able to also give us valuable information. But I mean, when you get these multifactorial etiologies, pretty much impossible to do without a liver biopsy.
Yeah, and I think what's important is that because of the increasing prevalence of MASLD, you're going to get a lot of comorbidity associated. If you look at the American Association Autoimmune Hepatitis guideline that came out, there's a specific section there on autoimmune hepatitis and MASLD co-involvement with the liver, and that always gives a poor prognosis. So maybe next time we look at MASLD, we'll try and pull out a AIH MASLD co-involved liver. But I think it's important to remember what FibroScan is as well. It's a very good screening tool, and it talks to liver stiffness. The stiffness is interpreted as fibrosis, but that stiffness can come from a variety of causes, including inflammation.
Yeah, but also the multifactorial etiology, I was thinking, was within the confines of MASLD. For example, you have a patient with metabolic syndrome who has a dyslipidemia, who's put onto a statin, who also
have a
drinks
drug
alcohol,
injury.
and has a, to differentiate how much is alcohol, how much is fat from a metabolic syndrome, and how much is
Well, I
from
think that's
statin.
where the meta-ALD aspect then comes in.
Yeah, and I think that's
the further sub-classification.
But I mean, Washington,
Anyway.
the big issue is to differentiate alcohol from non-alcoholic liver disease. I mean, or fatty liver disease, or MASLD. I mean, it can be very difficult, and a lot of the pathological findings you described occur in alcohol. Give us your cardinal features that differentiate. Mallory-Denks you find in both. Pericellular fibrosis is pretty distinct for alcohol.
True. So you'll notice you did say Mallory-Denk we find in both, but the extent of Mallory-Denk, but I think is more in alcohol. They talk about foamy degeneration that you see mostly in alcohol, and the satelitosis. The extent of the satelitosis or involvement of neutrophils is more extensive in alcoholic liver disease, as opposed to being patchy in MASLD or MASH. And I cannot overemphasize getting the clinical history and just asking how many units does this patient take. I know it's probably a very sensitive question, but it becomes important to both the managing clinician and to the pathologist to make a right diagnosis.
Yeah, I mean, biochemistry often can't help. I must say, Bilal, throughout our path sessions that we've been doing, I've been becoming more and more impressed with serum IgA abnormality as a marker for alcohol.
Yeah, no, absolutely. The immunoglobulins do add a lot. IgA, but remember, it's non-specific. It can just be in general alcohol too.
Mm. All right.
Yeah, I think if there's nothing further, let me just round up and close the meeting. I'd like to thank our sponsors, specifically the Gastro Foundation of Sub-Saharan Africa, University of New Mexico ECHO program, University of the ECHO India team. And I'd like to remind everyone to join us next week on Wednesday for the Gecko upper endoscopy session. I'm not sure what the exact title will be, but looking forward to having everyone join us. Thanks, everyone, and hope you all have a good evening.
Thanks.
Thank you.
Cheers. Thanks, Washington. Excellent. Thanks a lot.
Cheers.
Yeah.
Thank you, everyone.
Cheers. Bye.